உங்களுக்கும் ஜீவன் நல்லா தானே இருக்கும். அவங்க எது குழந்தை
Shilpa, you can start. Good morning and warm welcome to online anesthesia postgraduate teaching program on Zoom platform, sponsored by Akola and hosted by A1 Logics and aired by Anaesthesia TV. I wish you Merry Christmas on this great occasion. Today is the great day as we are completing 100 hours of teaching for postgraduates on Zoom platform. Actually, we have started this program in the 2nd January 2022, keeping in mind that the postgraduates should not be denied of theory classes for the sake of pandemic situation. We have formed a good team with high intellectual teachers of 6 members and drafted the topics meticulously from the textbooks like Miller. We are immensely thankful to the faculties, without which the program will not be a successful one. Without wasting much time, since my whole family is waiting for me to celebrate the Christmas, I wish to invite the legends of our faculty to felicitate this program. First, I call upon Tamil Nadu ISA President Amudarani Madam to facilitate this function. Over to Amudarani Madam.
Respected national office bearers, state office bearers, past and present executive members, esteemed and elite faculties of this program, dear students, very good morning to one and all. I wish you all a Merry Christmas. What a day today. It's celebrating Christmas with that too, Edward sir and all over the people from all over India. I am much delighted. Thank you so much, sir, for this opportunity. On behalf of Tamil Nadu ISA, we express our sincere appreciation and congratulate Dr. Edward sir for successfully completing his 100 hours of online program, which is it is a Herculean task. It's a commendable job, sir. I think it's an immense pleasure to be part of this program. Thank you so much. Every one of us here. Sincerity and sharing his evidence-based knowledge that with the constant efforts to each and every corner of this country is much appreciated. I wish for the next years to come. Wish everyone a happy new year, and thank you so much. Long live ISA.
Thank you so much for your kind words, madam.
I wish to congratulate the team also, sir.
Definitely, madam. Thank you so much, madam. Now I call upon IGA editor, Dr. Rajesh Gar, to say a few words about this program, sir.
Thank you so much, and good morning to all of you, and a very happy Merry Christmas. I think this is a wonderful day on this Merry Christmas when this online postgraduate teaching program by Dr. Edward Johnson is taking an success story of 100 sessions by all the doyens, great academicians who has taken it to such a great height. It is really very heartening and happy to see that our postgraduate students are getting benefited from this online program. And probably there may be many negative things about COVID, but there are certain positive part of it that we have moved out from our classroom teaching to another platform, online teaching program, which makes the great teachers, like even today we have a wonderful academician, a great teacher, a great human being, Dr. Pandya. Similarly, the other teachers who has been taking these classes. Otherwise, I think many postgraduate students meeting them and taking their sessions. But such type of online sessions has always helped our postgraduate students to learn from these experts, these doyens of anesthesia fraternity, and they have been helping a lot. I'm sure this teaching program will reach more greater heights, and not only from India but across the globe, people will get benefit by learning the various aspects of the anesthesiology. So thank you so much, and my best wishes, and again, heartiest congratulations for future success of this online postgraduate teaching anesthesia program and benefit to all the postgraduates. Thank you once again, and best wishes.
Thank you, Rakesh, sir, for your wonderful words. We feel very encouraged to hear such words from you, sir. Thank you very much, sir.
Yes. Thank you, Rakesh, sir. Now I call upon our senior member, that is Dr. Ravindra, sir, to felicitate this program, sir.
Good morning, everyone. This is actually this platform and the efforts of untiring Dr. Edward Johnson is one of the real commendable work which he is doing. It's, you know, it needs a lot of endurance to go on for so many days and so many, so many years continuously in the teaching program. In fact, this is one program which is meant for postgraduates, and probably it is helping the postgraduate teachers more than the postgraduates themselves. Such a wonderful program it is. And I bow down to Dr. Edward Johnson's efforts and the entire team of online anesthesia work that is going on. His WhatsApp groups, his Facebook groups, his everything is commendable. His quiz, which he is conducting for so many years continuously every Sunday without a break, and it is fantastic. We will all be waiting for it. Unfortunately, every week we cannot participate, but it is a wonderful thing. I appreciate you, Dr. Edward Johnson. Thank you so much.
Thank you, sir. Thank you so much for the kind words, sir. Now I call upon Dr. Gurudat, sir, to say a few words.
Yeah, first of all, I would like to congratulate Dr. Johnson and team and his team for this wonderful work they are doing for the past so many days, maybe years also. And the congratulations again for scoring a century of these classes. I know how important these classes are there for the postgraduates, because I used to conduct classes also. I know how hungry the students will be to listen to the classes and then to gain knowledge. And this work of Dr. Johnson and his team has made their life very easy all over the world, probably. So I hope the team is going to score a double century also. I wish them all success for future, this teaching program. Thank you, Dr. Johnson.
Thank you, sir. You are always my inspiration for your postgraduate teachings. Thank you so much for your kind words, sir. Now I call upon Joseph Rajesh, sir, to say a few words about this.
Thank you very much. Good morning to everyone. And really, thank you very much, sir. It's a wonderful day for all of us, as this online anesthesia program is reaching its 100th day. And nowadays, we don't hear cinemas celebrating their 100th days. So it is really a wonderful and it's a commendable job, sir, actually, because starting from the day one, continuing it for 100 days without any break, it is really a big task. And definitely our Edward Johnson, sir, and his team my friends, Dr. Shiva Prasad, Dr. Rajesh, and Gomati Madam and all. They've done the wonderful job, wonderfully handled and organized the program exactly in a way how a PG expects. And as Dr. Ravindra sir has said, apart from the PGs, it helped us also actually. The way sir has conducted the program, it shows his determination. Really a big salute for you and to your team, sir. And not to forget, I consider this as a privilege and I'm honored. Thank you thank you for considering me as a part of the team, sir. Wonderful job it was. Thank you, sir. Thank you.
Thank you so much. Shilpa, please make Dr. Assam as co-host. Dr. Assam. Before that, I may request Anji Gupta Madam to say a few words about this program. Anji Madam. Yes.
Am I audible?
Yes, ma'am.
Yeah. A very good morning, everyone. Wishing everyone a Merry Christmas and a Happy New Year. And I first of all want to congratulate Edward Johnson, sir, for conducting such wonderful course, which has been benefiting the postgraduate students everywhere. I must say that the postgraduates today are so fortunate that they have access to such kind of excellent teaching programs, because not every postgraduate student is fortunate enough to have teachers like Johnson sir and Bala Venkat sir and Gurudat sir. So it is definitely a boon to the postgraduate student to have online access to the online programs. And I have attended many of his lectures, and I was privileged to be given an opportunity to speak on the platform, this elite platform. And I am so impressed with the quality of the program which has been maintained by Johnson sir. He ensures that every lecture will be up to the mark. It is not that you just go and speak anything, and everything is covered on the topic. So my heartiest congratulations and best wishes for the further success of this program. And thank you, sir.
Thank you so much, madam. Thank you so much, madam, for your kind words. Now, I may request Dr. Assam sir to say a few words about this program.
Thank you, Edward Johnson sir. Good morning, everyone. And it's an honor to be here amongst legends in anesthesia and who's who in anesthesia, actually. And before I start, Merry Christmas to everyone, and I wish you all a Happy New Year. I think Johnson sir, much has been already said, but however, what I see is, putting hours of teaching, like what you, Gurudat, Bala Venkat sir does, is something, many of you, the way you take this teaching program to a different level, which we require and the postgraduates require, is something commendable and amazing. And this is not easy. I'm sure family must be suffering your family time and things. Not only that, apart from that, on WhatsApp, having weekly quizzes, quiz sessions, weekly teaching programs on WhatsApp, that requires a lot of dedication, because you need to have a sequence of events that goes in, or the quiz that goes in. It's not that easy. And you have handpicked speakers to speak about, and thank you for letting me the part of your program. Thank you so much, sir. We always look up to you, and all the best for your sessions. And most importantly, the postgraduates, it will be unfortunate if they don't go through the talks that you have already, because doing this on every Sunday without fail is something commendable. Thank you so much, and all the best for your future endeavors, sir. Thank you so much.
Thank you so much, sir. You are also a best postgraduate teacher, sir. I used to refer your notes before taking my classes for the postgraduates. Wonderful.
Thank you so much. Thank you so much. Thank you so much.
Thank you, sir. Now I call upon most respectful, honored faculty. Bala Venkat sir is also there. Sir, welcome, sir.
Yeah.
Sir.
Good morning. Am I audible, Dr. Edward?
Yes, sir. You are audible, sir.
Good morning. Wishing you a Merry Christmas. And it's such a nice coincidence that this very important day for celebration, apart from the merriest part, the Christmas, we also have another merrier part of celebrating the century of online anesthesia. Thank you, Dr. Edward Johnson, and the associate editors, Dr. Gomati, Dr. Rajesh, Dr. Shantini, Dr. Sivaprasad, Dr. Guru Sandhya, Dr. Sarva Vinodini, and the tech team of A1 Logistic, Dr. Sendil and Dr. Selva Kumar. Always, when accomplishments happen, it's because of the thought process of a leader, but consistency is maintained because of every person in the team. So at this important and crucial juncture, I would want to thank each one of you for having been a part of the process in creating an academic fervor for all those postgraduates who want to quench their thirst, want to learn more. And it is also very nice that teaching happens across. But there are few people who focus on certain specific work, like Dr. G.L. Ravindra in obstetrics, Dr. Sunil Pandya sir in high-risk obstetrics. And so what happens is, apart from the textbook, the knowledge that they gain out of doing very focused clinical work, the clinical pearls that emanate from their experience, when it is shared to the postgraduates, it means a lot. It's just not the theory. It's not just not passing the exam, but passing the true exam of life of making sure that the morbidity and the mortality of the patient is made sure that you minimize it to the best extent possible because of knowledge. Knowledge is power, and I consider that this platform gives enough power to the fraternity. And I also respect all the senior people who spoke before me, who do phenomenal work in education. Dr. Gurudat sir, all my DNB postgraduates, they will ask me permission to go and listen to Dr. Gurudat. And sir, I think you've been a absolute idol and hero in front of our postgraduate students who learned a lot from you, and they really revere you for that. And Dr. Azam, who has made a lot of inroads into educating the young minds. And I also see Dr. Anju Gupta, Dr. Joseph Rajesh, all of them who really want to contribute enormously to enriching our young minds. If all of us together work like this in synchrony, soon the world will look at us as a very reputed and respected anesthesia fraternity. And it's very important that we need to have a level playing ground. That's what it's meant in all international sports. You need a level playing ground, which means every person who has registered as an anesthesia postgraduate in this country should have an access to quality education. Some may be gifted to have great teachers and some may not, but to bridge the gap and to make sure that there is a level playing ground for every postgraduate, this platform, I think, gives enough succor to them. And I'm sure Dr. Edward Johnson and the team will keep going strength to strength, keep creating excellent sessions. And at the end of it, all that we need is it's the quality control. Every single person who finishes his or her education in the fraternity of anesthesia is updated with enough knowledge, which makes sure that what the mind knows, the eye sees. So to make the mind know the most of the things that the eyes needs to see, we need platform like this. And heartiest congratulations, and been very happy to been part of one of those sessions. and we continuously would like to be a part of your sessions. And we pray Almighty on this auspicious day to give you the energy, the vibrancy, and the power to choose the right topic, right speakers, and continue your journey. And we are all with you, sir. And my sincere thanks for the opportunity. And these are endeavors which have to be appreciated in abundance by all concerned. Thanks for the opportunity, sir.
Thank you, sir. Thank you so much, sir. Now I call upon Dr. Sunil Pandya, sir, to say a few words.
At the outset, I would like to congratulate Dr. Edward and team for doing a phenomenal job. Yes, to sustain for 100 hours of endurance, hard work, and a lot of meticulous planning. Importantly, liaising and coordinating with all the faculty, the topics, the selection of topics, the rhythm in which the things flows from head to toe, and the subspecialties. I think you have done, and you and your team have done a phenomenal job. And as all the stalwarts in anesthesia who have been spoken before me have rightly given their tribute, and I think it's you duly deserve a good round of applause to Edward and his team for doing this successful teaching the postgraduates. Yes, I follow each one of you, and I have seen that the notes of Dr. Azam or Kanyakumari's PowerPoints, and if you just Google search any topic, you get on ISA website or Kanyakumari website, and Azam's note, they just spring in front of you. So I think you've done phenomenal job, each one of you rather. So even Joseph, Aranju, and everybody, I would say. So please let us keep doing this good work and see that, as Dr. Bala said, his vision, let India be the global hub for education in anesthesia and take anesthesia to the different level which we have not seen. Congratulations again to Edward and team.
Thank you, sir. We are eagerly waiting for your lecture also, sir.
Yes.
Now I call upon Praveen Kumar. Praveen Kumar, say a few words. Dr. Praveen Kumar.
Hi, sir. Good morning to all my seniors and teachers. And thank you, Edward, sir, for providing me an opportunity to present a certain topic in this online anesthesia PG program. I would say practice makes a man perfect. And being an anesthesiologist, reading from a head to foot, everybody will not get a chance to operate on all kind of specialties. At the same time, we might be prone to do such cases rarely in our lifetime. So it becomes a duty to at least see and talk with the expert who does the cases which has been done very rarely. So this platform gives an opportunity for all the PGs and to teachers like me who does a certain rare cases to present on this forum and to get a discussion with the PGs. It really helps us. So I thank Edward, sir, in providing me such an opportunity to share my content in this forum. Thank you, sir.
Thank you, Praveen. Thank you. Viewers, you also can post your feedback in the chat box. Now I am going to present a presentation regarding how we reached this success of 100 hours, and also a few feedbacks from our faculties and postgraduates. So we have started this successful program in the 2nd January of this year 2022, and we have traveled 1 year. Well, it is a long journey with a lot of faculties. 86 faculties have attended this program through the year, and the viewers, it is around 50K, that is 50,000 viewers. Our program was telecasted in 7 channels. This statistics is taken from only 2 YouTube channels. That is 50,000 is from 2 YouTube channels. And it's also telecasted through the Zoom platform. That the statistics is not taken in the count as 50K. So it was streamed in 7 places. That is Anaesthesia TV YouTube channel, Anaesthesia TV Facebook channel, and Anaesthesia Cases, Anaesthesia TV Facebook, and Anaesthesia TV web portal, and Pain TV Facebook channel, Online Anesthesia PG Teaching YouTube channel, and our own Online Anesthesia Facebook channel. So how the success was possible? It is only because of this, our grand social network. We have online anesthesia YouTube channel with 8,000 subscribers, and also our online anesthesia Facebook with 3,000 followers, and online anesthesia WhatsApp group. In WhatsApp group, I have 10 WhatsApp groups. Totally 3,300 postgraduates are in the WhatsApp group. And also we have a Telegram group. And apart from that, we have tied a partnership with Anaesthesia TV. They are telecasting our program live in 5 channels. Thank you, Anaesthesia TV. And we can see the few consultant feedback who are not able to attend today's meeting. So this is from Christine Vittal. He is from USA. She has presented one topic on pediatric airway. She has written 2 books on the pediatric airway. We will listen to her message.
Dr. Christine Witten, an anesthesiologist from the United States who is honored to have been asked to participate in the online anesthesia program this year. As online anesthesia completes 50 classes and over 100 hours of teaching, I'd like to congratulate Dr. Edward Johnson and his incredible group of instructors for producing such a valuable educational resource. The amount of work required to create a training program like this is daunting, and they deserve a great deal of credit and thanks. Good luck in your future endeavors.
Thank you, Vittal. Now, it is a message from Sunanda Gupta, he is Emeritus Professor from Ludhiana.
It has been a pleasure to be associated with Dr. Edward Johnson and his team, who have started this innovative teaching program and for the postgraduates and the practitioners all over the country. And after marathon sessions, they have reached the first anniversary, and I find it has been a raging hit with all the postgraduates and the anesthesia practitioners in Udaipur and Rajasthan. I wish you a very happy association with all the stalwarts of our anesthesia fraternity and all the postgraduates, and the anesthesia practitioners are definitely going to be very happy and benefit from these sessions which you have organized. Thank you very much.
Thank you, madam. Now this message is from our most respected teacher, that is Pankaj Kundra sir. He is actually a mentor for me. He is an academic dean of JIPMER Pondicherry. Dear Professor Edward, you are doing an extraordinary job in teaching the students in most innovative way. MCQ's expertise is an extreme difficult skill to acquire, and you have mastered it. Keep it up, and all the best. Regards and best wishes always. Thank you, sir. Now, this message is from Dr. Partha Sarathi, who is Professor of Mahatma Gandhi Medical College, Pondicherry. The thirst never decreasing, the energy which is always increasing, the commitment which is far above the imagination, to make all speakers tune to his expectation and needs of the postgraduates, attending other webinars to speak and share in between, attending other conferences, adjusting for Sunday ISA meets, professor offline teaching, head and other non-medical issues in the college. He is mentioning about me. Some private cases in the evenings, examiner, IG, editorial board members, continuous reading by himself to update. Above all, the speed at which he responds to an academic question, his passion for the specialty. Such an unique person is Dr. Edward Johnson, my colleague, mate, and senior in undergraduate Tanjavur. All the best and continue your good work. Thank you, Partha, for your kind words. And Azam, he has already talked about our program. This is from Anju Grewal. He's a professor and head of there in the College of Hospital, Ludhiana. I have worked with Anju Grewal in writing IG editorial for few editorials. So congratulations to Online Anesthesia and its chief editor, Dr. J. Edward Johnson, and his dynamic team. It is an excellent forum to learn and understand anesthesia and its intricacies. The quality of the talk is excellent. The speakers chosen carefully, who enrich us all with their cumulative years of experience in anesthesiology. Kudos to the team and exhorting the PG students to stay tuned to online anesthesia for high quality content and enriching experience to make anesthesia safe for our patients. Warm regards. Thank you, Anju Madam. This is from Professor Elsa Varghese. He is a former professor and HOD of KMC Manipal. You have done an amazing job, Dr. Johnson. Thank you for including me also in your programs. Thank you, Madam. And this is from Naresh Paliwal. He is Associate Professor of Anesthesia, DRPD MMC, Amravati. He is a regular attendee of our all program. He congratulated the team for online anesthesia specialty, Dr. Edward Johnson, for taking so much efforts in completion of their uninterrupted online 50 classes. It is proving immensely valuable for the postgraduates and providing them an easy platform to learn various aspects of anesthesiology. I wish them all the best for the future. Thank you, sir. This is from Kala Madam. He is a retired anesthesia director of MMC, Chennai. Dear Professor EJ, every day before retiring to bed, I used to read anesthesia news academic messages that helps me to refresh my knowledge as well as helps me to a lot in the operating room for teaching. Especially your tip for the day, quizzes, etc. May God bless you and your services. Thank you, Madam. This is from Kannan Bodhiraj. He is a professor and HOD of Theni Medical College. Merry Christmas to Dr. Edward, sir, and team. Congratulations to online anesthesia team and grand success of the program. It is practically and academically very successful program for the consultants and the postgraduates for updating knowledge in the field of anesthesia and critical care. Best quality lectures series are delivered. I humbly request Dr. Edward, sir, and team to continue this CME program forever. Thank you, Kannan. He is my close friend. And this is from Nagalakshmi, Professor and Department of Anesthesiology, Sri Venkateswara Medical College and Research Center, Pondicherry. It is indeed a Herculean task to plan and program the academic schedule. Kudos to your relentless efforts to carry on the program without any break. The team deserves a great appreciation for planning and executing the program in a spectacular way. Thank you, Nagalakshmi Madam. This is my friend Kausik Joginath. Online anesthesia as a concept has grown strong over the past year, with renowned faculty taking classes on a weekly basis on important and a lot of times difficult to understand concepts. Was an ingenious method to connect budding anesthesiologists and clarify concepts to them. 50 classes in a year is a big landmark indeed. This remarkable achievement would not have been possible without a dedicated behind the scheme team. Hats off to Dr. Edward Johnson, sir, and the team for the lovely organization. Time has flown over the past, but each and every one of us as a participants has been the pilot of the flight, which is on remarkable journey. Wishing all the very best for many successful ventures to this team. Thank you, Kaushik. And very good friend of mine, Tushar Joksi from Baroda. Congratulations for 50 webinars and 100 hours of academic meet. You are a true teacher and academic buddy. Thank you, Tushar. This is from Santi Palraj from Tanjore Medical College, Professor and HOD. Online anesthesia series, a novel initiative and first of its kind in anesthesia academic program, meticulously planned and perfectly executed, was a great source of learning for students. All credit goes to Dr. Edward Johnson and his team for completing the Herculean task of 50 classes. Lucky to be one of the speaker. Congratulations and well done, sir. Thank you, madam. And this is from Professor Sivakumar from Pondicherry, PIMS Professor and HOD. It's a great work, selfless service in teaching postgraduate and sharing knowledge among your fellow colleagues. To do this consistently and so long needs dedication and passion. I really appreciate and admire your enthusiasm and passion in teaching postgraduates, sir. Kindly continue this good work to make our budding anesthesiologists achieve great success in their careers. I wish you good health, long life to continue your good work. Thank you, sir. This is from Ravinder, Professor and HOD of Anesthesiology, RVM Institute of Medical College from Laksamakapalli City District, Telangana. Hats off to you, sir. We are all knowing how much hard is the task you have taken up and achieved success in the form of enlightening us and clarifying us the basic and advanced concepts. Thank you, sir. This is Nirmala Devi, madam. She is one of my teacher working in Velaman Medical College. Hi, Edward. You have been teaching anesthesia for postgraduate students. It's very useful for postgraduates as well as consultant anesthesiologists. Postgraduates are gaining more and more knowledge. The way of your teaching is very good, and your teaching brings them a clear view of the topic. Admits your busy schedule, you are doing a great job. It's rare to find this kind of dedication and hard work these days. Once again, I congratulate on your excellent and fabulous work. It is quite rare to find such an amazing talent, enthusiastic person. May God bless you with good health, peaceful, long life to reach many more friends. Thank you, madam. This is Ravi Kumar, Professor of Malabar Medical College, Calicut. Dear sir, wonderful and useful classes to students and teachers. Thank you. This is Geeta, Associate Professor from Navodaya Medical College, Raichur. Hats off to you. It is not an easy task. Spending time with academic is very difficult, needs lots of dedication to become excellent teacher like you, sir. Conducting quiz for the PGs every Sunday, great, sir. On World Anesthesia Day, conducting quiz to frame questions on one day is difficult for us. Whatever teaching notes from this group, I say PGs to write, keep it in notebooks, helps a lot in both theory and practical exams. Thank you a lot, Dr. Edward Johnson, sir, for enlightening us with your excellent knowledge. Thank you, madam. This is Karthik Narayanan, Senior Assistant Professor from Vellore Medical College, Vellore. Amazing and awesome work. Informative. Please continue this marvelous journey. This is Ruba Holgande, Assistant Professor from Nijalingappa Medical College, Valkad, Karnataka. It gives immense pleasure to be a part of these academic classes. Very grateful for your timely guidance and proper coverage of different topics for postgraduates. Even me as a faculty have got its benefits immensely. Really commendable for all the faculty for taking the precious time on Sunday to educate us. Thank you once again. This is my MBBS classmate working in Qatar, Premalata. It is great work and appreciate your dedication and determination to train the PGs. Apart from PGs, we are also updated and well informed. Great work, John. Very proud of you. This is Prema Rajagopal. He is a senior consultant from Tindukal. Dr. Edward Johnson, his online anesthesia sessions have helped us to update and during the pandemic season. His choice of eminent speakers hats off with experienced ones and youngsters. He elevated Tamil Nadu weekly webinars to a greater heights. What a standard. His practical in-depth analysis of the several different topics made us Southeast. He is mentioning Southern people, I think. Southeast very proud. He surely attracted a big crowd. Oh man, a teacher of his caliber. We have reasons to celebrate. A gem from the southernmost tip of the subcontinent. He is a precious teacher, godsend. On his 100th hour on Christmas Day, he conducts a CME even today, speaks volumes about his dedication with absolutely no interruption. Seniors, juniors from all over the India speaks on recent new topics well covered. We were yearning for Sunday mornings. When we missed, we went to YouTube recordings. His respect to seniors awesome. Humility, thy name is Dr. Edward Johnson. Thank you, madam. Thank you so much. Now we will see some of the feedback from the postgraduates. Dr. Aimin Win. He is from Myanmar. He is a regular attendee of our program. Sir, I genuinely appreciate how incredible you are and your hard work is imperative to the organization. May you continue to success, sir. This is Vaishnavi. This online platform reaching out so many budding anesthetists. I have to change this one. What? Okay, so this online platform reaching out so many budding anesthetists has been very helpful. Anesthesia is very new subject to all of us when compared to any other subject because we are not exposed to its other subjects during our MBBS days. This platform has been a great learning resource for us, teaching us and clearing our doubts. Information provider has always been up to date with the reference quoted and put forward so well with such beautiful framed questions and images. Being within a hand's reach on our phones and tabs has been very helpful, making it easily accessible and to read on the go, be it while traveling or especially when we are in the operating rooms. I am grateful to Dr. Edward Johnson, sir, everyone involved in this amazing hearing learning program. Looking forward for more information and more learning to enhance my knowledge about anesthesia always on this platform. She has rightly pointed out, I have started this program because most of our postgraduates are spending their time only in the social media. So I thought of teaching through the social media, so it will be easily reached our postgraduates. Vaishnavi, thank you. This is from Nigeria. I don't know how to pronounce his name. Is Pew. Thank you, sir, for all this group has been very beneficial to me. This is from Pakistan, Dr. Imran. It's such a helping platform that due to it, we are able to clear many concepts which were either not cleared before or were not having any perspective in our mind. So these are postgraduates feedback from various parts of the India. And these are the feedback from Tamil Nadu postgraduates. So our program is well received throughout the India and also overseas. So it is a time to thank the sponsor Akrulla. The Akrulla has launched their product only in the July, but they have started sponsoring our program in the January itself. It shows their dedication to promote the education rather than the product. Thank you, Gangadhar sir, Tushar and Sankar. And it is time to thank the host A1 Logics, the founder Praveen Uttappa and Shilpa Mulki. Shilpa was always with us for the past 50 classes, sparing her busy Sunday morning. And behind the screen, she has helped us a lot. Thank you, Shilpa. I also thank the Anaesthesia TV, our partner, Pallavi Lande Madam, and the technical expert Rahul Chaubey. They have taken our program to the international level. Thank you, Anaesthesia TV. And I also thank our team. Without our team, this grand success is not at all possible. I thank Gomadi Madam, Rajesh sir, Soprasad sir, Sarva Vinodini, Shantini Madam, and Guru Sandhya for a wonderful backup you have given for the success of this program. And I want to say thank you for all your viewers' support. And as at the same time, I wish you all very happy New Year. So what is next? So so far we have completed 100 classes. Mostly I have covered the postgraduate topics. So what is going to be the next year? Whether we are going to continue it or not. So many of the feedbacks requested to continue this program. So I thought we are going to continue this program as a anesthesia update for the consultant. But the frequency will be once in a month. So we are expecting your continued support in the future endeavor also. Thank you to all the faculties and the viewers. Now we will go on to the scientific section. I request Suprasad sir, please take over the scientific section.
Hello, good morning. Welcome all to this 100th session. At this outset, I would like to wish all our participants a Merry Christmas and the season's greetings. And this session on anesthetic management of antepartum and postpartum hemorrhage is going to be delivered by a very eminent speaker. I welcome Sunil T. Pandya sir for this session. Welcome, sir.
Thank you.
To introduce sir itself is so inspiring. Sunil sir has finished his MBBS and MD from Osmania Medical College And he has done his PDCC in cardiac and neuroanesthesia from Chitrathirunal Institute in December 1996. The most important thing is, in 1997, he has started Prerna team anesthesia practice, which is the pioneer one, which, because in 1997, just after he finished his PDCC, he has started this. Where it's a time we might not even have thought about this. And he has successfully taken up the team, and he has also had worked in many very prominent hospitals like Fernandez Hospital, Century Super Specialty Hospitals, and he now heads the anesthesia, perioperative medicine, and critical care team at AAG hospitals in Hyderabad. Such a very inspiring profile, sir. We would like to follow you, and we are eagerly waiting to hear your talk on antepartum and postpartum hemorrhage management, sir. Welcome, sir. Over to you, sir.
Thank you, Dr. Shiva Prakash, for your kind words, and thanks, Edward, again for giving me this privilege to be here on this platform, online anesthesia teaching platform. I hope I do justice to your thoughts. Is my screen visible?
Yes, sir.
Yeah. So good morning all again. Welcome again on behalf of ISA Kanyakumari and Edwards and his team on this online teaching program for postgraduates. It's my privilege to be the 50th speaker for the 100-hour session. And I think I should be able to do some justice for the standards which Edward has raised the bars for with every session. So the topic that he was given to me was sometime to be held in June, but some emergency in the family. I had to discontinue in between, and I'm doing the topic today. Thanks, Edward, for accommodating me again at the nth hour. So this topic today is for anesthetic management of APH and PPH, antepartum hemorrhage and postpartum hemorrhage. A disclaimer, no conflict of interest. Importantly, what I'm sharing today in my presentation is all the cases have been my personal experience, and we have embraced with some evidence and what we do currently. It's not a textbook matter, but it's my personal experience. So if we look at the mortality of women in our country, it's hemorrhage is a leading cause of maternal mortality. Unfortunately, it occurs in a healthy woman who are ASA grade 1 at the time of conception, and then subsequently pregnancy becomes ASA grade 2 as they advance during the pregnancy. But it's one of the leading cause of maternal mortality. This was a fantastic study done by Umaram from Chennai, where they have analyzed the maternal death in India from the urban, semi-urban, rural setups in the country to see whether there are any changes in terms of maternal mortality and morbidity, different obstetric conditions, and where they have studied sepsis, hypertension, and hemorrhage. And hemorrhage was still the leading cause of maternal mortality across all sections in the country. Some of the urban areas, preeclampsia, hypertension has taken over and sepsis has taken over, but by and large, hemorrhage is still the leading cause of maternal mortality. If you look at the profiles of ICU admissions abroad, this was a wonderful paper by Dr. Uma Munur, Kalpratha Guntupalli. I don't know how many of you know Kalpratha Guntupalli. She is an intensivist from Hyderabad, but settled in Texas, Houston. She heads an obstetric critical care unit at Houston now. And Uma Munur is an anesthesiologist turned intensivist. And they had produced this paper in chest medicine. Of course, this was in 2011. And hemorrhage was a leading cause of ICU admission in their unit. And if you look at our ICU data, like Fernandez Hospital ICU data, it is the second leading cause of ICU admission, obstetric hemorrhage. When I talk obstetric hemorrhage, it's major obstetric hemorrhage, where the patient ends up receiving massive transfusion. And if we compare the data over the years, like even 2020, hemorrhage is the second most cause of ICU admission. So what are all the causes of major obstetric hemorrhage, the antepartum hemorrhage and postpartum hemorrhage? Yes, the commonest, of course, is the postpartum hemorrhage. The 4 T's which we have been told about, or which we have been taught about: the tissue, the tone, the tissue, the trauma, and the thrombus. But I have included 5th T. 5th T, I'll be elaborating as I go further into the lecture. But in a brief, 5th T is nothing but shift the patient to theater early so that you can stabilize the mother early. So 5th T is transfer to theater early rather than waiting and managing the labor room or in the ward. The major cause of obstetric hemorrhage, of course, are placental causes, the previas and the morbidly adherent placentas, the vasa previas, the abruption, the cooler uterus, the HELP syndromes, the acute fatty liver of pregnancy, amyloid fluid embolism, IUFD, sepsis, and others. I've included anemia as a cause of major optic hemorrhage, which contributes to most of this condition, but anemia per se also is responsible for hypotonic uterus post-delivery. So it can contribute, plus also it induces postpartum hemorrhage. In addition, obstetric-induced coagulopathy, like we see in hepatic failure following AFLP or HELP syndrome, or any of those viral hepatitis or sepsis-induced hepatic failure, hepatitis E, A, are still not uncommon in our countries because tropical diseases are still affecting during our seasonal variation. We see dengue, hemorrhagic fever, leptospirosis, von Willebrand disease. These are all the things. In fact, we have on an average every 2 months one von Willebrand case complicating pregnancy. And of course, with the advancement in the infertility treatment, we are getting more and more elderly gravidas with complex thrombophilic patients who are on anticoagulants antepartum period. Obviously, they bleed, and especially patients with metallic heart valves who are on oral anticoagulants, they sometimes bleed. So how do we plan for anesthesia in a patient who has a potential to bleed or who is going to bleed, or who is bleeding already and we need to plan anesthesia? So you may be called for a parturient to give anesthesia for a parturient who has been bleeding on hemorrhagic shock, or you may be called for a anesthesia to give anesthesia to a parturient who is likely to be like morbid adherent placenta, or probably anticipated blood loss, like hypotonic uterus, paucity of PPH and other things. So when we consider anesthesia part, we need to look at the following 5 questions. What is the likelihood of major optic hemorrhage perioperatively? Is it low or high? If it is high, then yes, straight away we go for general anesthetic, which is much more stable. And if the patient is bleeding torrentially, hemodynamically unstable, then what should be our anesthetic strategy? Patient is bleeding but still relatively stable. Can I manage and continue under spinal or CSC, which I have already given? These are the decisions which are very important, which are very relevant. We all have come across where we have given spinal and subsequently patient lands up for major optic hemorrhage. At what time you want to put a tube, or whether you want to continue the spinal. Simple decisions sometimes, but sometimes they are critically important as well. But most importantly, it is always the assessment of airway and back, which is very, very important. Like suppose if I am planning a cesarean section in a patient who is likely to bleed torrentially, like morbidly adherent placenta with a difficult airway, I don't want to struggle with putting a tube into the trachea when the patient is bleeding, because my concentration should be on maintaining blood loss or maintaining intravascular fluid volume. So in this case, straight away, I will go for general anesthesia, planned general anesthesia. But suppose if I see a patient is intubatable airway, relatively easy airway, and then I would definitely go for regional if there is no contraindication, and SOS basis I turn into convert into general anesthetic because it's a easily intubatable airway. But when the patient bleeds, do not struggle for airway, bottom line. Other important factors that govern your decision is anemia, low platelets, critical platelets where the regional is contraindicated, or patients with bleeding disorders like hemophilias, and as I said earlier, preeclampsia, HELP syndrome, where the platelets can sometimes fall to critical levels where regional is contraindicated, amyloid fluid embolism, dengue, and of course, any of those patients where regional may be of questionable risk. So all these are all the conditions where you need to take a call, like placenta previa in a primary gravida. I will not be happy with just simple placenta previa and primary gravida. I want to know the localization of placenta. Is it anterior placenta? Is it a battle lower placenta where the placenta covers the entire os and goes posteriorly, or is it posterior placenta previa? Posterior placenta previa may not bleed because when the obstetrician delivers the uterus to the lower segment, the placenta is not in the way, but posterior segment of uterus, they don't retract, they don't contract, and there will be constant ooze. Sometimes this ooze can lead to significant fall in hemoglobin and fall in blood loss. So posterior placenta previa is an entity, should not be ignored. Then, of course, abruption placenta, partial abruption, total adhesion, scar dehiscence. Most of the scar dehiscence are fibrous scar dehiscence. There is not much of bleeding. But suppose there is a traumatic scar dehiscence or patient in active labor and the scar dehiscence and uterines are involved, or any of those angles are involved, then the patient can have torrential hemorrhage. And sometimes simple procedures like manual removal of placenta or third stage of labor, a focal adherent placenta can lead to torrential bleeding. Past history of postpartum hemorrhage is very, very important, because past history of atonic PPH, the recurrence rate is quite high. And of course, when you have a grand multi over-descended uterus like polyhydramnios or multifetal pregnancies like twins and triplets, of course, we don't see triplets and quadruplets now because of fortunately fetal reduction surgeries. But yes, sometimes we do come across over-descended uterus because of polyhydramnios, especially diabetics, GDMs. And of course, unruptured ectopic, where there's a potential to bleed. A word of caution: a primary gravida especially may not be a primary, because they may be having a concealed pregnancy history of MTP or myomectomy or metroplasty. So any scar in the uterus in terms of DNCs or myomectomies and metroplasty can lead to adherent placenta, and you have to keep this keep this factor in mind. And you need to take this history in confidence when the mother is around, when the in-laws are not there, because they are often a concealed history. And we have had this patient landing, and we land up in problem. And subsequently, when we probed post-operatively, then they gave a history when we took the patient and the mother in confidence without in-laws presence. So certain things we need to do in a very subtle way to save the family as well. Other important factors that land up in peripartum hemorrhage is morbidly adherent placenta, the scar ruptures, the stuck placenta, the coexisting vascular diseases like large aortic and splenic aneurysms. We've had a good amount of series of aortic aneurysms, splenic artery aneurysms complicating pregnancy, which they have a potential to rupture, especially if they're allowed to go into spontaneous labor. And of course, grade 3 and grade 4 unbanded esophageal varices. These are all late referrals to our unit, where the patient comes with a cirrhotic portal hypertension, non-cirrhotic portal hypertension, but has grade 3, grade 4 varices. They have not been banded. And being a Fernandez Hospital, being a dedicated perinatal center, we don't have interventional advanced gastrointestinal GE interventions are there. And you need to have a strategic plan. You need to have those appropriate things taken, tubes, or to resuscitate this part in case they bleed, because we've had, I still remember a couple of patients, they ruptured the varices peripartum period. And of course, subclinical coagulopathy due to any cause. And anesthesia in class 4 hemorrhage, when the patient has lost 50% of blood volume, or when the patient has landed with cardiovascular and embolic shock like amniotic fluid embolism, or there is complete uterus, complete abruption, covular uterus, uterine inversion. Uterine inversion is one entity where you see all types of shock. You see hypovolemic shock, hemorrhagic shock, neurogenic shock, and of course they have severe pain. And so multiple shocks are seen in one entity. And uterine ruptures, or ruptured ectopic, or any reason where the GCS is less than 8. Especially we have had several cases last couple of years due to COVID, severe ARDS patients landing up in PPH, or patients with neurotrauma or polytrauma, or any coincidental space occupying lesion with poor GCS. So all these things you need to take into consideration when you are planning anesthesia, like class 3 hemorrhage, subclinical epidemic fluid embolism, indwelling epidural catheter cited for labor anesthesia. Now landing up in major obstetric hemorrhage. Would you want to continue epidural because patient is relatively hemodynamically stable, but patient is bleeding? So all these things, yes, we need to keep in mind when we are planning. If you look at our PAC chart at Fernandez Hospital, one of the investigation finding is location of placenta, which I have included. This is very, very important, because as a part of PAC, many a times our colleagues, they don't have habit of looking at ultrasound report, reading the ultrasound report, but make it a point to see, because sometimes there may be a communication lapse from the obstetrician to the anesthesia team, especially freelance practitioners, and on table you detect there is anterior low-lying placenta, or a placenta, anterior low-lying placenta previous cesarean section. So all these anterior low-lying placenta with previous cesarean section or previous scar should be considered as placenta or invasive placenta or morbidly adherent placenta, unless until put otherwise, and manage accordingly. This PAC and this point, this should be one of the take-home point. Other important point when you plan anesthesia is the pre-anesthetic check. Yes, you need to do airway assessment and back assessment for every scenario. Anatomically easy airway, anatomically challenging airway, physiologically challenging airway. When I say physiologically challenging airway, we know that when the patient has lost 50% of blood volume, they are acidotic, they are hypothermic. And sometimes the pH is 7 and 7.1. And if you have to put a tube with little fentanyl or midazolam, it induces asystolia, it induces cardiac arrest, because when you have deranged physiology like septic shock with hemorrhage, with severe metabolic acidosis, the moment you give even little fentanyl or midazolam, there is vasoplegia, intense vasoplegia, and they go in for shock. So planning intubation in anatomically, physiologically challenging scenarios is very, very important. And we know that despite 6 hours of fasting, they have the inherent tendency for risk of aspiration. So acid aspiration prophylaxis is mandatory. And of course, always look for spine, musculoskeletal abnormalities. Examine the back. If you're a male anesthetist, have a nurse in the PSC room and examine the back, because we have seen many times scoliotic back or a patient with I've got beautiful pictures, but I don't want to not this presentation to show those pictures, but importantly, examination of back is very, very important, because sometimes you miss scoliotic spines or rotated spines or instrumentation in the back where region is really contraindicated. So all these things you need to remember. And of course, obstetric contraindication for neuraxial block also have to be kept in mind. So in a nutshell, you have a simple airway, simple spine. The choice is yours. You can decide either GA or spinal, but generally all patients in our hospital, the protocol is start under neuraxial anesthesia so that you can establish maternal bonding. But yes, it's a demanding spine intubatable airway. We still prefer regional anesthesia like the combined spinal epidural or spinal, even if you're anticipating major obstetric hemorrhage. If it's a demanding airway and easy spine, we straight away go for GA, especially when you're anticipating major blood loss. And of course, in this case, there is no choice but go for planned GA, because when you go for planned GA, you can spend some extra time if it is needed for intubation using video laryngoscope or fiber optic scope. But importantly, always ease of securing airway, ease of intubation, post-op ventilation, all have to be planned meticulously before you give anesthesia to these parturients. It is very important. And importantly, the risk of difficult airway aspiration versus remote risk of neuraxial hematoma. As I say, remote risk of neuraxial hematoma, because most of these bleeding parturient, they go in for peripartum coagulopathy, peripartum thrombocytopenia, deranged INRs, and what is the risk of hematoma I'm going to incur or accrue is very, very minimal, but that has to be kept in mind. So if you are planning a GA for a bleeding parturient, like either because of antepartum hemorrhage or a postpartum hemorrhage, yes, informed consent is mandatory. Blood transfusion consent is mandatory. Blood transfusion consent, massive transfusion consent, especially when anticipating major blood loss, is mandatory. And this consent of blood transfusion is valid as per the NABH for 24 hours. So suppose if you're transfusing blood again the next day, a fresh consent has to be obtained. Acid aspiration prophylaxis is again a mandatory checklist before you induce the patient. Have a baseline ABG, always better, because it gives you not only the lactates and the hemoglobin, but also gives you the electrolytes, which are very important. And see that the enough blood and blood components are reserved. As a rule, in adherent placentas or this thing, we reserve MTP pack 1, that is 4 Paxes and 4 FFPs are reserved and kept ready for disbursement. And of course, keep the emergency drugs and difficult airway cart ready. Wide bore venous access is what is required. When I say wide bore venous access, at least 116, 118 is mandatory. No pink, no blue, no yellow. And artery line, preferably if you're anticipating major hemorrhage, early arterial line is mandatory. You don't transfuse the line. Insert the line, strap it. And when you feel the patient is bleeding, then you can transfuse the line. Because when the patient bleeds and loses 50% of blood volume, then you struggle to secure an IV arterial line. You may waste considerable time unless you have help, and sometimes you delays resuscitation. So have a prophylactically placed arterial line, especially when you're anticipating major obstetric hemorrhage. Call for experienced help early rather than calling at the nth minute. And see that the surgical safety checklist is done so that we don't compromise on the maternal safety. Antibiotic prophylaxis generally in our hospital give cefuroxime 1.5 grams at the time of induction, or when you give spinal, a single dose for elective cases. And ETCO2 is mandatory, of course. And in patients, when the patient, if you are giving anesthesia to a bleeding parturient who has lost 30 to 40% of blood volume, then do not use propofol or thiopentone. Go for ketamine, suxamethonium, rocuronium, sugammadex, of course, with little bit of midazolam and fentanyl. But again, ketamine with midazolam again is myocardial depressant. Ketamine with 50% of blood loss itself is a myocardial depressant. I'll come to it a little later, but yes, the ketamine also has to be given slowly in a parturient who already is bleeding profusely. Okay, so and subsequently, because we know that inhalation agent like sevoflurane or desflurane or isoflurane, whatever you're using, may not be there because of low volumes, low blood pressure. We put these patients on KFM mixture, wherein we take 200 milligrams of ketamine plus 200 micrograms of fentanyl plus 5 milligrams of midazolam in 50 ml syringe and run at 5 to 7 ml per hour. This induces adequate sleep and it prevents adequate awareness. And when we do BIS monitoring, you maintain BIS around 40 to 55 range, which is adequate enough to knock down the awareness in parturients. And of course, when the patient bleeds, what you need to do is damage control resuscitation, not overzealous resuscitation. Damage control resuscitation. I'll come to it again later. But monitoring and prevention of lethal quad and low threshold for post-operative ventilation. This is what I was talking about. If you are maintaining KFM mixture, the BIS, that is bispectral index monitoring that you maintain is around 50, less than 55, which is good enough for adequate depth of anesthesia, is what is achieved. Because if you just switch off the inhalation agent because the patient is bleeding, then the risk of awareness is there. And if you look at the NAP5 audit, NAP5 audit is National Anesthesia Project Audit. I think it is, I remember it is a NAP5, which was an awareness of under anesthesia. The incidence of awareness in obstetric patients is almost about 3 to 5%, very, very high. So you have to keep this factor in mind. A patient may be pain-free, but she may be aware. So knocking down of awareness is very, very important. Importantly, as an anesthesiologist and perioperative physician, whenever you're dealing with massive obstetric hemorrhage on table and giving anesthesia for bleeding parturient, remember few important things which are very relevant. All these patients who receive massive transfusion, they are prone for post-operative lung injury, TRALIs and TACOs, transfusion-associated acute lung injuries, transfusion-associated circulatory overload, TACOs, and all these patients, they warrant lung protective ventilation. So conventional ventilation of 8 to 10 ml of tidal volume is no longer recommended even for ASA grade 1 patient for a non-obstetric surgery also. So lung protective ventilation should be the norm, wherein we give about 6 to 7 ml per kg of predicted body weight, not the actual body weight, predicted body weight. Restrictive fluid strategy, permissive hypotension. The concept of permissive hypotension should be followed. Normothermia is very important because when we are giving massive transfusion, massive fluid infusion, the temperature drop is very, very significant, very fast, very rapid, and maintenance of normothermia is relevant because we know that hypothermia can cause coagulopathy, hypothermia can cause acidosis, and the vicious circle of coagulopathy, acidosis, hypothermia can lead to the circle of death. So temperature management again should be one of the single most important point in your anesthetic management. Yes, serial ABGs are very, very important because we know that massive transfusion can cause hypocalcemia, can cause hyperkalemia, can cause hyperlactatemia, can cause metabolic acidosis, and prevention and hyperchloremic metabolic acidosis if you are giving excessive overzealous normals and fluids. So ABGs, when I say serial, that means at least once in 2 hours or once every hour when the patient is bleeding or when you are resuscitating has to be done. If you don't have the facility of doing ABGs, at least get once or twice during the surgical period. And if you feel the patient has lost more than 50% of blood volume, you have given massive transfusion, then yes, elective ventilation should be the norm, at least till the patient normalizes, till the patient bleeding ceases, because many a times the surgeon, they close the abdomen with oozy abdomen, and sometimes there is a risk of re-expiration. So if there is a risk of re-expiration or if there is a pack in the abdomen, then better to plan for elective ventilation. If you don't have facility for elective ventilation, if you're doing all these things happen in nursing home level, alert your tertiary care center, the anesthesia, the critical care team, the obstetric team, so that as soon as this damage control resuscitation is done, patient is stabilized and transfer in a stable condition to a higher center, because we don't want her to lose her life during transit. Very important. And once the patient stabilizes, DVT prophylaxis is very, very important. And as I said, as a protocol, prevention of post-operative pulmonary complication strategies. And prevention of post-operative pulmonary complication strategies starts with preoperative spirometric exercises. If the patient has COPD, of course, this is a healthy population, we don't see that. But intraoperative lung protective ventilation, Then lung recruitment maneuver before you extubate the patient. Very important, because we are given massive transfusion, prolonged surgery. At least the physiological shunt, the VQ shunt, which is normally about 7 to 10%, can go up to 25 to 30 to 35%. And we need to minimize this shunt, minimize this atelectasis. So lung recruitment maneuver is very important. How do you give lung recruitment maneuver? Is sustained PEEP of at least 25 centimeters of water for about 45 to 50 seconds is very important. But yes, there is a small risk of rupturing bullae, especially the patient is an asthmatic or they have family history of spontaneous pneumothorax. You have to be careful. But this is very important. So when you plan a spinal anesthesia or a neuraxial block in a patient who has potential to bleed, how do we go about? Yes, as I said, informed consent, alternate plan has to be discussed. This is a part of your routine patient education during PAC. So when you're planning neuraxial block, like either spinal anesthesia or combined spinal epidural anesthesia, alternate plan B has to be explained in case of bleeding, in case if the spinal fails or if the CSE fails. Then of course, as I said, transfusion consent, acid aspirin prophylaxis, all these things are very, very important. And it is important that you monitor nasal capnometry. I am very fascinated by capnometry because capnometry is one instrument that tells you, in addition to the ECG, which gives us continuous ticking that patient is alive, capnometry gives us the continuous ticking that patient is breathing, which is very important, because once the patient is closed under the drapes, and sometimes you give a little bit of midazolam or this to allay anxiety, and you will not be able to monitor the chest movements. And ECG pulse oximeter, before the seizures or before they become brady or this thing, there is a gap of almost about 45 to 50 seconds. And we know that pulse oximeter takes an average of at least 6 to 7 pulse beat before it gives a value of 98 or 99. So you need to remember this lag in pulse oximeter. So and ECG, before it seizes or before it becomes ready, when the patient stops breathing, it takes a little time. So nasal capnometry is mandatory. You get a simple nasal cannula which can be connected to the capnometer, regular capnometry. But this is very, very important. Especially we have made it a mandatory protocol. Even if you're doing a ASA grade 2 routine elective cesarean section or this thing, if you're giving a nasal cannula, put capnometry, monitor, so that once it becomes a norm, it becomes a safety culture. So nasal capnometry should be one of the second take home from today's talk. Call for help early. So, and of course, don't compromise on the surgical safety checklist, antibiotic prophylaxis. We have taken a norm now. Previously, it was under care of surgeon, but now anesthesiologists start taking basically the prevention of SSI, surgical site infection. And of course, spinal, our protocol is 8 to 10 milligrams of bupivacaine with fentanyl. And generally, we give morphine for all cases, 100 to 150 micrograms of morphine. And this dose, generally, the respiratory depression is very, very uncommon. I have not seen so far, but yes, we need to have naloxone available in the ward. And generally, we keep our patient under our radar for at least 24 hours. And suppose if the patient has labor epidural converted to cesarean section in a patient who has a potential to bleed, then yes, 2% lidocaine with adrenaline and fentanyl and bicarb is what we give combination. When I say potential to bleed and epidural for labor, these are all the patients who had previous history of postpartum hemorrhage or previous history of hypotonicity or family history of PPH. So where normal delivery is not a contraindication, and generally we give epidural for most of the cases. It is about 60% of our patients deliver under epidural analgesia. And of course, not to forget the thing which I've already mentioned. So either you can plan epidural or a combined spinal epidural, and generally we use continuous saline flush technique, which is nothing but to minimize bloody taps. We know that the incidence of bloody taps, the inadvertent cannulation of epidural catheter into the venous plexus or Batson's plexus is almost about 5 to 7% in obstetrics. So once you identify the epidural space, thread the catheter till the Huber point, and once the catheter is till the Huber point, connect a saline filled syringe and start flushing the catheter and advance the catheter simultaneously. So while doing this, it's basically you're doing hydrolavage, and the tip of the catheter, if any blood vessel is there, it sways away and you can minimize bloody tap. This is very important because most of these patients of major obstetric hemorrhage or patients who are on anticoagulants or this thing, they have a tendency to bleed. You can minimize bloody taps. You can give sequential CSE or you can give non-sequential CSE. or you can give single shot spinal, whatever technique you want. But importantly, see that when the patient bleeds intraoperatively, you give targeted resuscitation, prevent hemodilution, because hemodilution also can cause coagulopathy, and prevention of lethal clot and safety net. Safety net is nothing but watching for signs and symptoms of neoaxial hematoma, because sometimes epidural catheter can come out spontaneously when the platelets are low post-operatively, and you need to keep this in mind. So we always secure the catheter with clamps so that the catheter comes out at the desired time. I must tell you that these clamps, again, we have seen a couple of times or many times, the catheter sometimes comes out with the clamp also. So you have to keep this in mind. But yes, definitely some securement of the epidural catheter has to be done. So that was in brief about planning of anesthesia. But more importantly, as an anesthesiologist, we have to be thorough with the ABCs of maternal resuscitation in obstetric hemorrhage. And obstetric hemorrhage is a major obstetric hemorrhage can be defined as a catastrophic hemorrhage where the hemoglobin drops to critical levels, or it's also synonymously with critical hemorrhage, or a torrential hemorrhage where the patient loses blood volume in just few minutes. Because we know that the term gravid uterus receives 25 to 30% of cardiac output. And if it is a multifetal pregnancy, polydistended uterus, polyhydramnios, the cardiac output, you have to add another 5%. So almost 800 to 1000 ml per minute. So if the patient remains atonic for 5 minutes, you can have virtual exsanguination. The mother loses the entire blood volume in just about 3 to 7 minutes. So when you have such a magnitude of hemorrhage looming at you, surviving the blood loss and maintaining circulation at the head end is what is important, while the surgeon simultaneously stop and control the hemorrhage. So maintaining circulation from our side and measures to stop and control hemorrhage from the surgical side have to go hand in hand. So how do we survive the blood loss? And I have developed a 10 commandment approach in my hospital, wherein it is basically, this is our approach and what we do and what we follow. So first and foremost is maintaining circulation and constitute a multidisciplinary team from our side, from the anesthesia side, and from the surgeon side as well. So they do their part, we do our part. Why it is important to our part also is because there has to be one person or two people at the head end who will help the main anesthetist in terms of securing additional line, in terms of securing arterial line, in terms of giving fluids, warming the fluids and all those things. And one person dedicated for assessing blood loss, quantification of blood loss, and liaising with the blood bank manager, office manager, so that the blood is appropriate, blood comes to the theater. Very, very important, because if one person has to do all the things, you may miss out certain things. You may miss out giving calcium, you may miss out sending labs, you can miss out sometimes sending blood gases. All these things have to be kept in mind. And of course, calculating allowable blood loss is very important. Quantification of blood loss, resuscitation of fluids, defining endpoints of fluid resuscitation. Okay, enough is enough now fluids. I need to go for blood. So what are the endpoints of fluid resuscitation? When do you want to give blood and blood products? How much to give? What are the endpoints of blood and blood components? Understanding fluid flow mechanics, and of course, transfusion strategies, monitoring and achieving microvascular hemostasis. You may achieve good coagulation targets, coagulation goals, but patient still loses. So achieving microvascular hemostasis is of paramount importance. And post-operative care, ERAS protocols, even in MOH. And bottom line, the 10th step, most important step of all the steps is 3 C's and D's. This is the one step which will prevent all those litigations and problems. Communication, counseling, consent, and documentation. Consent is important because many a times you end up sacrificing the uterus. We have had at least a few handful of cases where we had to sacrifice the uterus in a primary gravida patient with IUD. Because that was considered to be life-saving. So, and imagine a patient in a general anesthesia, adult patient cannot give consent for her uterus removal. So how important it is to communicate and counsel the patient. So major obstetric hemorrhage, our aim is to maintain perfusion of important organs, prevention of cerebral hypoxia, prevention of tachycardia or bradycardia, because tachycardia is better than bradycardia, because the moment a patient bleeds and has bradycardia, it's a very ominous sign. And of course, try to prevent oliguria. Again, if you see oliguria, that means your resuscitation goals are inadequate. So how do we maintain circulation? The step 1 is call for help early. Multidisciplinary team is very important. I was telling you this uterine flow, and patient can progress from class 1 to class 4 hemorrhage within few minutes. And importantly, because of the physiological reserve they have, 50% of blood volume expansion happens in a term gravida patient. And so a patient may not have the classic telltale signs of hypovolemia until they lose about 30% of blood volume. So subtle signs are tachypnea. So do not ignore the tachypnea. So if you see the patient may progress to class 4 within few minutes, but blood pressure may be normal, maybe partially marginally decreased. But by the time it is decreased with tachypnea, tachycardia, patient already is progressed to class 4. So there are certain bedside mathematics which are very important. And the simple thing is obstetric shock index, OSI, is what we call it, the simple pulse rate by systolic blood pressure. So generally, if it is in the range of 0.5 to 0.9, the risk of major optic hemorrhage or resuscitation is less. But if the OSI is persistently more than 1.1 at 10 minutes or 1.1 at 30 minutes, that means 75% of these patients, they require massive transfusion. So you have to keep this in mind. And OSI is a simple bedside mathematics. And other thing which, as an anesthesiologist, which we do a day in and out is rule of 30s. When the increase in heart rate is more than 30, when the respiratory rate increases more than 30, especially under spinal anesthesia, in the regional anesthesia, and then that is another important thing why I want nasal capnometry to be on. Or if there is a drop in systolic blood pressure more than less than 30 millimeters of mercury, more than 30 millimeters of mercury, you do not put less than 30 ml per hour. And hematocrit, if you are getting it checked, generally we have hemoq in our theaters, then immediate action is necessary because these are the patients who bleed torrentially. Step 2 and step 3 are quantification of blood loss. Very, very important. Quantification of blood loss is not assessment. Because assessment, we know that 40% of blood loss in obstetrics is underestimated, and we need to be very, very careful. So you need to quantify the blood loss. Quantify the blood loss because surgeons generally count what is seen in the jars, but what is there on the floor, what is there on the mops, what is there on the table, these are the things that are ignored, and we need to keep this in mind. Also, not to forget the specimen loss, because we know that 70% to 70% of the weight of the uterus or that is removed is nothing but blood. So you need to weigh the specimen, and also that also is very important when you're calculating blood loss. So once you are quantifying the blood loss, our aim is to restore the circulating fluid volume either with fluids or with blood and blood components. But it is important that you maintain the circulatory blood volume. So first and foremost is fluid, the crystalloid resuscitation. Our aim is to maintain adequate intravascular volume, adequate oxygen carrying capacity, adequate clotting function that we prevent coagulopathy because of overzealous resuscitation, maintenance of electrolyte balance, because we know that excessive overzealous normal saline resuscitation can cause hypertrophic metabolic acidosis, and overzealous blood and blood components without replacement of calcium can cause hypocalcemia, and of course there is a normothermia. So crystalloids are the mainstay, and of which ringal lactate is the fluid of choice. Normal saline also can be given, but not beyond 2 liters, because we know that hypertrophic metabolic acidosis can set in, and that can be deleterious. And we know that of all the crystalloids, they stay in water. In intravascular compartment, they just escape to third space, and they don't stay in intravascular compartment. And role of colloids in major optic hemorrhage is less, especially if there's a background sepsis, because we know that if the patient has sepsis and atonic PPH during surgery, do not give colloids. Do not give colloids. The only colloid that is recommended is albumin. If you're giving starch and if you're giving gelofusine, then it can cause acute kidney injury, anaphylaxis. You have to be cautious. And we know that normal saline osmolarity is 280 to 295, normal serum osmolarity. And dextrose should be avoided because it is a very, very hypoosmolar solution. It can cause dysarthritis. And overzealous normal saline resuscitation, as you can see, this was one of the patients who received almost 3.5 liters of normal saline, and you can see the chloride almost is 113, and potassium is 152. So hypernatremia, hyperchloremic metabolic acidosis. So you need to approach judicious approach. Low volume resuscitation, maintain a palpable pulse. Do not restore normal blood pressure. A systolic BP of 90 is good enough, and maintain adequate perfusion. pH of less than more than 7.28 or less than around more than 7.3 is what is important. Yes, you can take the help of noradrenaline to maintain the perfusion, but see that the clinical targets, if the patient has neuraxial block, she should be responsive to commands. She should be alert. if she's irritable, if she's restless, then better to put it. Do not allow that stage to come, because those are the signs of cerebral hypoxia. Very, very important. So understanding the critical blood loss and oxygen debt. This is, I've kept these slides, next 4-5 slides only for postgraduates. It is very, very important. If you look at the normal oxygen delivery to the tissue is 1000 ml. God has given us enough reserves, 4 times more than what we need. And if you look at the normal oxygen consumption is 250 ml per minute, but the supply is 1000 ml per minute. And we know that oxygen extraction ratio by the tissue is about 22 to 30%. Maximum happens in cardiac. So if you look at the oxygen content in the cardiac output, depends on 4 parameters: circulating volume, which we maintain by giving crystalloids and sometimes colloids. Colloid, again, as I said, should not be given routinely, especially in sepsis. If the patient is a non-septic case, you don't have blood in hand, then probably 15 to 20 ml per kg of low molecular weight starch can be given, but do not go beyond that because it affects coagulation also. Maintaining of cardiac contractility is very important. So that means prevention of acidosis, prevention of hypothermia, and prevention of any drugs that can cause myocardial depression, like even bolus ketamine of 1.5 to 2 milligrams per kg, ketamine with benzodiazepine combination, or ketamine benzodiazepine with nitrous oxide. If you're giving nitrous oxide oxygen combination, they're all myocardial depression, and of course inhalation agent. So maintenance of cardiac contractility is very important, and maintenance of oxygen saturation, hematocrit. So let us take this. This is the venous side. This is the arterial side of the circulation. And if you look at the 15 grams hemoglobin, of course, we don't see this value in a pregnant patient. But if you have a 15 grams of, this is these are the mathematics. I have taken this chart from Edward Life Sciences website. But if you see when the hemoglobin is 15 grams, cardiac output 5 liters. In pregnancy, cardiac output is 7 liters. It is increased. And you see the oxygen delivery of almost 1000 ml. Let us say now hemoglobin, patient bleeds torrentially, and the hemoglobin drops to 4 grams, critical level. And if you see hemoglobin drops to 4 grams, the oxygen delivery is 288 ml. As I said, oxygen extraction happens at 22%. So if you see the normal oxygen extraction, is less than 25. But if it is 25 to 50%, you can measure this by taking sample from the IJV tip. It shows increased extraction, and 55 to 75%, it shows increased lactate and cellular dysfunction. If the SCVO2 or if the oxygen extraction is more than 75%, then there is cellular death. So you have to remember that SVO2 of more than 75% is normal. 50 to 75%, it shows increased extraction of oxygen. And SVO2, that is VBG is from the IJV tip. If it is 25 to 50%, it limits these are the limit extraction. It indicates there is lactatemia happening, there's cellular dysfunction, and there's cellular death if the SCVO2 falls to less than 25%. So doing a blood gas from the central venous line is of paramount importance. So starting blood is very important at early point. The transient trigger should be raised appropriately. Do not allow hemoglobin to fall to critical levels. The critical level in pregnancy is 5.2 grams. In non-pregnancy is 4 grams. So when I say critical level is nothing but the Krebs cycle, which is oxygen dependent cycle, stops. So there is the aerobic metabolism no longer happens. The anaerobic metabolism, that is the Embder-Meyerhof pathway, where the substrate is glucose, is converted to lactate and pyruvate. This lactate and pyruvate, they go into Krebs-Hanslat cycle to release 38 moles of ATP, water and carbon dioxide. Water is excreted through the urine and carbon dioxide exhaled through the lungs. So if you don't have oxygen, there is a pasture point at the mitochondrial level. PO2 in the mitochondria drops to less than 5 millimeters of mercury. Then this anaerobic metabolism sets in, and you see more of lactate production. And if you still don't give blood when the hemoglobin is critically ill, you raise the inotropes, you raise the vasopressors. Momentarily, you may improve cardiac output, but eventually what happens is the patient can go into irreversible vasoplegic shock, irreversible. So we don't have to tilt the balance. So see that you need to maintain adequate triggers, appropriate triggers. Do not allow this to occur. This was a patient, I still remember, a patient with mitral stenosis, moderate MS, hemoglobin, unanticipated hemorrhage happened on table, and hemoglobin fell to 2.6 grams. Of course, we could revert it immediately. But importantly, what I want to convey is ETCO2 is a fantastic monitor. EtCO2 is a fantastic monitor, and you can see when the EtCO2 volume decreases despite putting a tube, there's an indicator that patient is losing volume. And you can also notice ST depression. So when the patient, even with a patient with normal coronaries, if the hemoglobin drops to less than 4 grams, they have ST depression, myocardial ischemia. Upon that, you give eutotonics like methyl ergometrin, and sometimes they can induce coronary spasm, and you have to keep vigilant. Understanding fluid mechanics is very important, because when the patient is bleeding like this, there is no point in using these cannulas. Very important, because when the patient is bleeding profusely, torrentially, we need to aim at keeping the intravascular compartment at least 70% full. And this can happen only if you have at least 16, 18 and orange cannulas. Very, very important. Of course, I don't want to go into the details, but appropriate size cannula is very, very important. So appropriate transfusion triggers in a parturient who is bleeding is: do not allow hemoglobin to drop clinically to less than 7 grams. Raise the transfusion trigger at 7 grams in the patient who is bleeding massively, so that you can get blood in hand and you can start appropriate blood and blood components. And if you have the facility of intraoperative cell salvage, nothing like it. Multi-specialty hospitals, they have these devices. At Fernandez, we don't have, but at AIG, yes, we have the cell salvage mechanism, but we don't have obstetrics at AIG. So it's a paradox. So the dedicated perinatal centers, they don't have intraoperative cell salvage because the usage is less, and every cell salvage costs about 20,000 rupees, the disposable cost. But the beauty is the oxygen carrying capacity of the red cells is preserved, and immediately the 2,3 DPGs are well preserved, and they carry oxygen immediately the moment the salvage blood goes back to the patient's circulation. It's very, very important. This is one of the grim reality in our country. When we talk about massive transfusion, the gross availability mismatch between the urban and rural setups. If you look at the blood donation, I wanted to spend a little bit of time on this, because the PGs may not know that for every 1,000 people where the blood is required, there are only 30 donations. And this ratio drops to less than 5 in rural areas. So always at the time of PAC, encourage blood donation. The bank can give you money only if you deposit money in the bank. Okay, so blood can dispense blood only when they have blood and blood components. So you need to make a protocol that every cesarean section in our hospital who is a high risk, we send 2 donors to the blood bank. We don't have a blood bank, but we have liaison with 4 or 5 blood banks around the Fernandez Hospital. And of course, keep your massive transfusion protocols in hand. And the concept of hemovigilance, again, this from the postgraduate viewpoint is very important. Hemovigilance is the thing that is coming up in most of the hospitals. And the concept of hemovigilance is nothing but bidirectional tracking of adverse effects and adverse reaction because of blood transfusion. Bidirectional. So from the time of donation to the issue, and from the time of issue to the patient transfusion. And so every blood that is received by the clinician, there should be a blood adverse form attached, and we have to fill up this form back. So they send it back. Even if there is no adverse effect, write no adverse effect and send this form back to the blood bank so that they have the registry. Other thing that you have to remember is DIC in a pregnant patient sets up rapidly, even a normal patient. Of course, they have HELP, AFLP, or amniotic fluid embolism, when coagulopathy is inherent. So that has to be kept in mind. So non-obstetric cause of coagulopathy are hepatitis, systemic sepsis, overzealous crystalloid resuscitation causing a dilutional coagulopathy, all have to be prevented. And lethal quad. Quad is nothing but hypothermia, acidosis, coagulopathy is what we have been taught, the classical lethal triad, but the quad is hypocalcemia, which we tend to ignore, especially when you're giving more FFPs, more FF cryos, and more PRBs without replacement of calcium. So how do we raise a transfusion trigger? When to order what? So as I said, do not allow hemoglobin to fall less than 5.5 grams in pregnancy, that is critical level. Raise the trigger at 7 and give supplemental oxygen. Early endotracheal intubation and prevention of quad is very important. Do not, especially when the patient is bleeding like this. These are all pictures from of our past patients. But importantly, when the patient has lost more than 50% of blood volume, we go for packed cells and components. So generally prefer always leukodepleted blood cells. Again, leukodepleted blood cells, leukodepletion done in the blood bank, not while you are transfusing with a Paul blood filter, leukodepleted filter, because if you are giving massive transfusion with a Paul leukodepleting filter, it goes very slowly. So leukodepletion has to be done by the transfusion specialist in the blood bank. Why leukodepleted blood? Because we know that why do you want to give WBCs in PRBC? PRBC packed RBCs contains WBC also. And WBCs are the one which are notorious for trallies. And why do you want to give a component for trally when it is not needed? So always prefer leukodepletion. Yes, it comes with additional cost. But if you look at the Western blood banks, they don't give a regular PRBC at all. The norm, when you ask for packed cells, it is always leukodepleted packed cells. And probably we need to move towards that. Whether you want to give whole blood or component, generally we prefer component therapy because getting a whole blood on an urgent basis is impossible. Because more importantly, it contains, if you're storing blood for beyond 1 week, the 50% of coagulation factors are lost. There are no platelets. What you have is only packed cells and volume. So even you don't have component, coagulation factors. So if you are giving FFPs, you are giving cryo, and you are giving PRBC, the yield of hemoglobin is better with PRBC. Yield of coagulation factor is better with FFPs and cryos. Generally, we prefer irradiated blood. Ideally, if given a choice, irradiated blood is preferred, especially if you have donors from the kith and kin. Do not give blood donation from brothers, sisters, siblings, parents to the patient because it can cause graft versus host disease. So one way to circumvent that is irradiation of blood. But again, in emergency, it has not, you don't have that much of time, but keep that point in mind. Again, we don't prefer female donors in reproductive age group because they also carry alloantibodies from their partners. So always healthy male donors is the choice. And if you can have NAT blood, that is nuclear amplification tested blood, is important because you can reduce the window period of HIV, HBsAg, and THCV to less than 1 week. So nuclear amplification test is, again, it's not a mandatory protocol as per the NACO guidelines, but it helps us in minimizing transfusion transmitted diseases like HIV, HBsAg, hepatitis, and THCV. So what goals should be? Hemoglobin of more than 7 grams, APTT should be less than 1.5 times the control, and platelet should be at least more than 80,000. Fibrinogen of more than 250 is what our control, and ABGs maintain that a pH of more than 7.3. Very important. Just for the sake of postgraduates, if you don't know bedside mathematics, one RDP or pool platelets gives 5,000 to 7,000 platelets, raises platelets by 5 to 7,000, and one SDP raises 30 to 40,000. One packed cells again raises the hemoglobin 1 to 1.5 grams, sometimes 2 grams also. It all depends on the body weight and the blood volume. Need not be that 1 gram of hemoglobin and 1 PRBC. It all depends on the body weight and blood volume. But keep these simple things in mind. But importantly, FFP is group specific, SDP is group specific, and type specific, and cryos are only group specific. And we have an MTP protocol, that is massive transfusion protocol. The moment you say MTP1, 4 PRBCs, 4 FFPs are issued, and automatically things for MTP2 are ready in the blood bank, which means they'll screen for SDP. They give they'll be ready with 6 PRBCs, 6 FFPs, and 8 cryos. You have to remember that once you order FFP, the thawing time for FFP is about 25 to 30 minutes. So you have to keep that in mind. Never thaw FFPs, never take frozen FFPs and keep it in the warm water because it forms clumps and you'll not be able to transfuse them. So always thaw it in the machine in the blood bank, and that becomes relevant, that becomes important. Achieving macrovascular hemostasis is of paramount importance because we know that fibrinogen and tranexamic acid play a very, very important role. So when the patient is, you are anticipating major optic hemorrhage, but this is one case where you can give 1 gram of tranexamic acid. If the patient continues to bleed, repeat 1 more gram of tranexamic acid after 30 minutes. Beyond that, there is tranexamic acid, 3rd dose and 4th dose are not necessary. In addition, fibrinogen. Yes, if the fibrinogen levels drop significantly less than 100, it indicates clot failure, and you have to maintain fibrinogen levels because pregnancy is a state of hyperfibrinogenemia, and you have to maintain fibrinogen of at least 220 grams or milligrams per deciliter. Very important because we know that 150 to 250 milligrams is low for obstetric population. Less than 150 milligrams of fibrinogen per deciliter impairs hemostasis. Less than 100 milligrams, poor hemostasis, and if the fibrinogen is less than 50 milligrams, then there is no clot formation. And the sources of fibrinogen are FFPs, cryos, and fibrinogen concentrate. Yes, If you want to prevent volume overload, you can go for fibrinogen concentrates. They are available, but importantly, expensive. Yes, I already mentioned about tranexamic acid. Give. If you have point of care testing, nothing like it. Take targeted volume blood replacement is ideal, but not many centers. At Fernandez Hospital we don't have. At AIG, of course, we have it, but as I said, not much of upstick happens here. Importantly, I must tell you that if TEG is not there, not to worry. What we do is we just take 5 ml of blood in the syringe, keep it by the side of the patient on the table horizontally, and after 5 minutes, till the syringe. There was a beautiful study from Raichur. I remember it came in IJ or some of the Indian journal only. Very fantastic study, and they could see that you can see the clot formation. Very crude test, but nevertheless, it's an important way to measure bedside coagulation. And always send PT, APTT, fibrinogen at least every second hourly during surgery. You have to remember that when you're sending a PT, APTT at 0 hours, by the time you get the report, patient have bled another 1 liter. So correction has to be kept of this additional 1 liter of blood loss, which has happened in the interim period from the point of sending. So that dynamics have to be kept in mind. As I said, arterial line is very important. CVP is not essential initially. Yes, CVP line is not essential initially, but arterial line is very important because beat-to-beat monitoring is what is important. Because when you see this trace, hypovolemic trace, you can see contractility is very well preserved. This is the patient, and of course, urine output is the best cardiac output monitor. We have unometer, which gives us a 5 ml even minimum blood, and unometer is so. Sometimes you can use unometer or urometer to assess the blood loss. Very, very important. But importantly, urine output maintenance is the crude cardiac output, poor man's cardiac output. If you have a warm core temperature, 0.5 ml of kg per hour of urine, it's a good cardiac output. Your perfusions are good. But yes, always use this additional methodology to assess the perfusion, and lethal quad prevention is of paramount importance. Core temperature monitoring already I've discussed. I don't want to again spend some time, but it is very important that you maintain, give warm fluids. This is the fluid warmer. You can give massive transfusion through this warmer cassette. The priming volume is almost about 230 ml of this cassette, but it's infrared warmer. And generally we prefer infrared warmer over the blood and water bath warmer, because water bath warmer can sometimes cause nosocomial infections, because water bath can cause, bugs can be there. So as I said, the endpoints of transfusion, hemoglobin of more than 7 grams, ideally yes, 8, but not 9 or not 10. Don't aim at hemoglobin of 10 grams or hematocrit of 30. 8 grams is enough. Even if the patient has cardiac problem, not an issue. And platelets of more than 75 to 80,000, fibrinogen of more than 250 milligrams is what we desire, and choline lactates. Most importantly, do not extubate this patient on table, because especially the patient is acidotic and hypothermic. Electively ventilate. And as I said earlier in my introduction, if you don't have facilities, transfer her to a higher center, or at least ventilate in the theater till the patient is warm, or till the risk of re-expiration increases. Recombinant factor 7A, again, for the sake of postgraduates, hardly it is there. Of course, we have had a series of 17 cases in pregnancy where we've given RF7A. But yes, when all the measures fail, despite normal correction parameters, despite normothermia and normal pH, if the patient is still oozy, then you can give a recombinant factor 7A. The dose is 40 micrograms to 90 micrograms per kg, which comes to around about 4 to 5 grams, sometimes 6 milligrams. And each 1 milligram is almost 40 to 50,000 rupees. So one dose correction, it costs almost about 2.5 to 3 lakhs, very expensive and not so cost benefit analysis, if you see, not very high. Cell salvage, definitely it's helpful. Plasma and blood substitutes, especially Jehovah's Witness. We've had many cases of Jehovah's Witness, but once we explain and take a consent to the magistrate, they agree for blood transfusion. Yes, we don't have true Jehovah's, at least in India, I've not seen. But when you discuss and elaborately, because even in a low risk obstetric case, we don't know which patient are highly unpredictable. But if you look at the literature, there have been cases where they have managed blood and blood substitute in Jehovah's Witness, the major optic hemorrhage, even critical hemoglobin. But again, there have been few maternal deaths also because of the patient didn't consent for blood transfusion. So you have to keep this in mind. If you have a Jehovah's Witness with anticipated major obstetric hemorrhage, involve a magistrate-based consent about blood transfusion, because that's something which is very, very relevant, very important. And of course, not to forget our friendly subspecialty of a radiologist and interventional radiologist, because many a times, despite doing peripartum hysterectomy, there is a stump bleed or there might be bleed inside, and you need to have embolization or cath procedure. So you have to keep that also in mind. And post-operatively, you need to look for immediate transfusion complications like fluid overload, TRALI, transfusion transmitted sepsis. The transfusion transmitted sepsis is highest with platelets and least with cryos and FFPs, and PRBC is the second most component, because PRBCs are stored at 4 degrees to 6 degrees, cryos are stored at -20 and -40, and PR platelets are stored at the room temperature 25 degrees Celsius on agitator. They are not frozen because we know that platelets should not be frozen, and the risk of transmission of infection highest with platelets. So use platelets judiciously. And just because this patient has had major hemorrhage, long duration surgery, they should be ambulated early, because these are the patients who are prone for DVTs and pulmonary complications. And as I said, our protocol is neuraxial analgesia is a technique of choice in our hospital, even in anticipated hemorrhage, and we convert them into GA. And with good analgesia, they are up and about, and they recover very, very fast. And you can minimize prevention post-operative pulmonary complications by early spirometric exercises. So just to conclude, the anesthesia in a parturient who has a tendency or potential to bleed antepartum or postpartum, CNB, neuraxial block is the most preferred, but yes, risk versus benefit. Difficult airway versus ease of spinal, difficult back versus ease of intubation, and versus coagulopathy, low platelets. All these things have to be kept in mind when you are planning anesthetic technique. General anesthesia is not mandatory for placenta previa or adherent placenta, provided we do risk versus benefit analysis. If you are having a difficult airway, very difficult airway, and adherent placenta is there, then planned GA is better. Okay, bleeding parturient, GA is a safe bet, because we don't want to activate epidural, especially if they have, despite they have indwelling catheter which you have put for labor analgesia, the patient bleeds, go for GA rather than activating epidural catheter, because we know that sympatholysis, sympathetic block can be difficult to manage with profound vasodilatation. Organ protective strategies, very, very important. You are perioperative physicians, you are intensivists, and see that organ protection starts intraoperatively. Judicious use of fluids, judicious use of vasopressors, inotropes, because we know that vasopressors and inotropes can cause splanchnic ischemia, bowel ulcerations. So have a low threshold for arterial and targeted resuscitation. Avoid NSAIDs, especially if the patient's coagulopathy. Numero uno for volume replacement is ringer lactate crystalloids. And if you ask me, balanced salt solutions should be preferred, but ringer lactate is also good enough. But overzealous fluid resuscitation should be avoided. And hemorrhage drills should be carried out very frequently. Tranexamic acid should not be forgotten. And fibrinogen early cryos and FFP should be given for macrovascular hemostasis. Cell salvage devices, radiological interventions are at immense benefit in appropriate cases. But importantly, you have to prevent, identify, manage immediate complications, short-term complications, and long-term complications following major obstetric hemorrhage. When I say long-term complications, Sheehan syndrome, all these things are very, very important. So the last slide is dynamic assessment is very important, and keep replacing laboratory workup, and triggers and endpoints have to be defined continuously. So remember that blood is a bloody organ, it's a fluid organ. Blood is a bloody business. Use judiciously, use appropriately. Transient triggers, raise appropriately. Too much of blood, too little of blood, too late of blood are eternal perils. Hemovigilance is the need of the hour, and minimize transfusion associated related complications. Very, very important. 3 C's and D's are excellent, are very, very important. And all these things you can have in place, provided you do regular drills. Every 4 months, every 6 months, you do these drills, hemorrhage drills, eclampsia drills, and importantly, introspection of the outcome of all your patients. So bottom line, we don't have a blood bank, but we get a massive transfusion at least once in every week, or two cases every week, and not a single death so far. So thank you very much for your patient hearing, and I'm open for questions. But just to inform you that next conference is Ahmedabad, kindly register. And the forthcoming workshops on obstetric simulation I'm doing are as follows. If anybody is interested, you can attend them. Thank you, Dr. Edward, for the opportunity and privilege. Any questions I can take?
Thank you, sir. Wonderful presentation. Super sir, you take
Yes,
up the.
yes, sir. Thank you, Sunil sir. That was a really very wonderful presentation. The century presentation was, which is really apt. Having you as speaker, sir. All the content was very nicely arranged, good slides, and very informative. Thank you very much, sir. And there are questions which are coming, and I think you have covered this topic so well. You were answering all the questions as the questions were coming, sir. The yeah, first question is about how to initiate the massive transfusion protocol. I think you've detailed it and how that MTP 1, 2, and 3 goes on, sir. What is restricted fluid therapy in bleeding patients, sir?
So restricted fluid therapies do not aim at BP of 120/70 or a baseline blood pressure. The baseline BP is 130/70. We don't want to achieve those targets. The restricted fluid therapies try to achieve a palpable brachial pulse or a palpable radial pulse, or at least a good plethysmographic pattern on a pulse oximeter probe. If you're seeing a good plethysmograph and a pulse oximeter probe in a warm patient is good enough, because if you're achieving a map of 65/70, whatever the microclots are formed at the microvascular level, you're dislodging those clots by overzealous fluid resuscitation. So the microclotting is prevented and you end up losing more blood. So a restrictive fluid strategy is nothing but don't go for excessive overzealous fluid resuscitation. You can just assess the blood loss dynamically and early transfusion triggers. Do not wait till the hemoglobin drops to 5 grams. Raise the transfusion trigger to 7 grams, because most of the obstetric hemorrhage or obstetric practice happens in nursing homes where you don't have blood banks. By the time you order blood and procure blood, it takes at least about minimum 2 hours. Or at least minimum 1 hour, unless the blood is ready or ready for dispensation. So you have to keep this in mind and see that the damage control resuscitation from the surgical side, appropriate usage of uterotonics and all those things, they go hand in hand simultaneously. But giving only crystalloids till the patient bleeds is again should not be done. So restrict fluids and raise appropriate transfusion triggers appropriately at appropriate time.
Thank you, sir. The next question is on which quantification method of blood loss is the best? What do you use, sir? Because the bucket one which we showed is really, we've not done it. It is really nice to do it. We'll also follow. But
So
which one is the best?
Generally, what we do is, if you look at the suction jar, if you look at the mandatory protocol of the suction jar, you have to keep at least 100 ml of hypochlorite solution at the bottom. That's the protocol in our hospital. I presume it's the same everywhere, right? Because we don't want the handlers, our healthcare workers who handle the suction jars to clean up at the end of surgery should be exposed to any of those things. So by the time they clean the jars, whatever the fluid is there, biological fluid is already killed by the hypochlorite solution. So first 100 ml is hypochlorite solution. And subsequently, we have a marker pen given to the Daya or the housekeeping chap in the theater. So once they open up the uterus, they suck out the liquor. So once they suck out the liquor, the first mark they put is the hypochlorite solution. The second mark they put is the amount of amniotic fluid that has come out. And suppose if the patient is having ascites, even that ascitic fluid and amniotic fluid also counted. And subsequently above that is blood. And if this nurse is using any saline for dilution or mopping the mouth, that also is kept into count. And so quantification is nothing but you look at the exact or approximate to exact amount of blood that patient is losing. Second important thing is our mops have been standardized. We have a 12x12-inch mop with 12 layered gauze piece. So if the mop is fully soaked, we have done this exercise in our hospital. We have fully soaked dripping mop is about 60 to 70 ml of blood. And partially 50% soakage is almost about 50% of that thing. So you need to standardize your mops in the hospital, because most of the mops, they come from one company only, but they're all radio opaque mop with a barium or a lead thread in between and with the tail. So importantly, you soak this mop and do the standardization in your hospital. So the number of mop count, the partially soaked, fully soaked, and importantly, the specimen loss and everything is quantified and assessed. And the pad which is kept underneath the patient also, roughly, if you look at the 1 square centimeters fully soaked pad is equal to 1 ml of blood. So you do this exact quantification, and you end up giving appropriate. So end of the day, many a times when we give this massive transfusion, next day when you check the hemoglobin, it will be around 9 grams, 8.8 grams. It's okay, but don't achieve 13 grams and 12 grams of hemoglobin. Because again, that is over, and neither achieve 6 grams of hemoglobin this first POD. If you are giving enough transfusion despite the hemoglobin is 6 grams, that means patient is still bleeding from the time of end of surgery, and you're still the patient is bleeding inside. So you need to put your ultrasound probe on the tummy and do e-fast and look at identify whether the patient the collection is there. And always we put drains in this patient so that it is easy to monitor. But again, I must tell you, due respect and regards to my surgical colleagues or our surgical colleagues, they are not used to putting drains appropriately. The drain placement has to be done in the retroperitoneal pouch, behind the uterus, and one drain in the paracolic gutter on the left side or right side. And it should be a tube drain, 28 French or 26 French tube drain, not Romovac. So that you have a free drainage and the monitoring becomes a little easy. Many times they put the drain for the sake of putting it will be in between the momentum, so nothing comes out. So you have to see that you lift the bowels and put the drain in the paracolic gutter and one drain in the pouch of Douglas, so that those are the most dependent position when the patient is in proper position in the ICU, and the drain fluid is collected and you can estimate the blood loss and appropriately transfusion happens.
Wonderful, sir. Really good ideas and nice suggestions, sir. Sir, what is the end point of fluid restriction? You have already told us not to give more. So what could be the end? Where should we stop it, sir?
Yeah. So once the patient loses 40% to 50% of blood volume, you have started fluid. So generally, endpoint should not exceed more than 3 liters.
Yes,
Thumb rule. When the patient lost 50% of blood volume, you need to replace, at least as I said, don't aim at filling the intravascular compartment 100%. You aim at filling, keep it the intravascular compartment filled by at least about 75 to 80%, which we can see. I know CVP is not a true guide, but yes, if you are used to ultrasound, you can just look at the IVC from the mid-axillary line. You can put a linear probe or curvilinear probe, and you can see the collapsibility index or distensibility index if the patient is on controlled ventilation. But all these things are possible now because we are now tech savvy, and we need to embrace these newer modalities of volume assessment intraoperatively also. And if you are a cardiac anesthetist, you can put a probe. We have a TE probe available in our department. We just put a probe into the esophagus and do a TE, and you can assess the cardiac contractility and volume, which is the most sensitive and most easy way to do it. But again, not everybody is equipped with those things. So at least a quantification of blood loss is, if you are doing it, if the patient has more than 50% volume, thumb rule, do not give more than 3 to 4 liters, maximum 4 liters, and you need to start giving blood and blood components.
Yes, sir. Thank you, sir. Do you have any experience on reconstituted whole blood, sir? What could be the role? Reconstituted whole blood.
See, basically, again, whole blood is reconstituted whole blood. That means you are
making together all the components again.
Basically you're giving different components, no?
Yes, sir.
Yeah.
So you prefer to give all the components as separate entities, right, sir?
Separate entities straight away, yes. Because reconstituting again, it involves opening up the bags and being the advantage.
Can we go for early fibrinogen transfusion?
Absolutely. Absolutely. Because many a times we don't monitor fibrinogen. We just send PTINR and APTT. I would always recommend to send fibrinogen early, because if the fibrinogen is less than, sometimes fibrinogen goes undetectable in massive hemorrhage, because we are given so much of crystalloids, the fibrinogen is undetectable. So let that stage not come, because, and cryos, if you have all the blood in hand, like you have PRBCs, you have FFPs, you have cryos, everything. What I do is, or what we recommend is, give coagulation factors simultaneously, initially, so that before we give Paxils. If you are giving Paxils when the patient is having coagulopathy, whatever Paxils you are transfusing, patient is going to lose. So first give coagulation factors, And then raise oxygen carrying capacity by giving intubation and ventilation 100% oxygen and with KFM mixture to knock down awareness, and simultaneously give pack cells so that you maintain everything. But do not delay in giving coagulation factors to the patient who is bleeding profusely or who has lost 50% of blood volume.
Yes, sir. One question from me, sir. Usually, this obstetric hemorrhage patients, they will transit into disseminated intravascular coagulation at one point of time, sir.
Very easily.
Yes, sir. Do we have any method to detect at that point which we are going into DIC? And in case the patient is in DIC, would fibrinogen and tranexamic acid produce a counterproductive effect?
See, the thing when the patient is in, I must tell you that counterproductive effect of fibrinogen and tranexamic acid is almost not seen in obstetric hemorrhage. We are fortunate. We are fortunate. But having said that, I always said that DVD prophylaxis is also important post-operatively, so that we can circumvent that because if you are giving, if the INR is 1.1 or less than 1, that means there's a severe prothrombotic state that you have achieved. That should not happen. So see that these patients, you ideally monitor clinically, yes, but more importantly by the blood loss which you are assessing, because in a major obstetric hemorrhage, patient loses almost 15 to 20 to 30 liters of blood. When I say blood loss, 15 to 20 to 30 liters. The highest we have seen is 32 liters of blood loss because the patient required multiple entry and exit from the theater. But yes, when you have such magnitude of hemorrhage, you end up giving 200, 300 units of blood and blood compounds over a period of 2 to 3 days. So monitoring is very essential. And I must tell you, obstetric hemorrhage, you end up giving 60 to 80 units of blood. A major obstetric hemorrhage, especially we get bad referrals from outside, and that has to be done on a very war footing basis. If you delay, you miss the bus. So if you allow the pH to drop to 7.1 and you don't come back to 7.3 or 7. At least 7.3 and above, you tend to go into the circle of death. So our aim is to bring the pH back. So at least do a blood gas. So blood gas, if the pH is less than 7.2 or 7, that means your acidosis is still there, DIC is still there, and myocardial depression also sets in. So it has the multi-pronged therapy that you need to keep in mind, but give blood adequately and compounds adequately and enough. But again, as I said, when I say enough, not too much. So that comes with experience. I still remember initial days we had hemoglobin of 11.8, 12.2 grams in the first POD, which was undesirable. So you see that you give it in such a way that look at the field. Again, Dr. Edward was pointing out that most of the anesthetists now are social media savvy, and this thing has invaded into the theaters also. I'm sorry to say, but my colleagues also, they're sometimes glued onto the mobile while anesthesia is on. So they are not vigilant on what is happening in the surgical field. And this is one entity, I think, where we should put an anonymous ban of allowing mobiles into the theater, so that they are more watchful on the surgical field, and they themselves can assess and quantify and appropriately correct. If you are away from the field, even for a few minutes in major obstetric hemorrhage, we are missing the bus, because sometimes we miss a bleeder or the surgeon misses a bleeder in their anxiety, which you have spotted, and you can guide them. Yes, patient is still bleeding, BP is still low. I think there was a bleeder behind, below the bladder, in between the bladder. Or you can guide the surgeon also. This has happened several times. So be vigilant. And vigilance and monitoring the continuous surgical field is also very important from the anesthesiologist viewpoint. And I'm sure if you are vigilant and if you are not hooked to your mobile, you can assess without TEG and other things, and you can still achieve a hemoglobin of 8 grams or 9 grams on the first POD, despite giving 80 to 90 units of blood transfusions.
Thank you very much, sir. A very wonderful talk. I think very important, and this content will be carried to all the postgraduates, consultants across web, and this will definitely have an impact when they face a case with obstetric hemorrhage. Thank you very much, sir.
Thank you. Thank you, Dr. for being there.
Sir, most of us, we are concentrating the resuscitation towards coagulation, MAP, and saturation. They forget about the resuscitation, about the hemoglobin, cellular hypoxia, acidosis. So you are rightly pointed out that point, sir. Wonderful. Thank you very much.
Thank you, sir. Thank you.
Sir, sir.
So, yes, sir. Next on agenda, we have our esteemed faculty to share a few words with you on how we took over this one year of teaching. So I invite Gomati ma'am to first talk few words on this happenings around this 1 year. Gomati ma'am. Gomati ma'am, can you share a few words with us, ma'am?
Yeah. And it was a beautiful topic. I just got lost in your topic. Very beautiful topic, sir. Thank you for that. And thank you, Edward, sir. It's been, I think this 1 year has been very incredible being here and being with my teacher, Professor Edward, sir, was my teacher when I was a postgraduate, and being with everybody else. It was an awesome experience. What else is there to say? Thank you, sir.
Thank you,
And
ma'am.
thank you, Shiva. Thank you.
Thank you, ma'am. Next, I invite Dr. Sarva Vinodini to share a few words.
Good day, all of you. Thank you, Sunil sir, for that mind-blowing lecture. This 1 year was actually so fabulous. I extend my thanks to all the viewers and all the speakers who came and spoke in our platform. And without all of you, this would not have been possible. Thank you, Edward sir, for creating such a wonderful team. So happy to be a part of this team. Actually, we six were like 6 phases of a cube or 6 phases of a dice. We just kept rolling over this 1 year, compensating each other, contributing to each other, and supporting each other. So that's how we were able to pull along this one whole year. So I'm so glad to be a part of this team. And the one thing that united all 6 of us was the passion towards anesthesia and the passion towards teaching and learning. In organizing this, we have learned a lot, not just in anesthesia per se, also non-academically, we have created such a good bond, and we have learned so much. So thank you for all the good wishes that you all have shared with us. Thank you so much. It is a great opportunity to be a part of this esteemed team. Thank you so much.
Well said, Sarva. You have reflected all our teammates' feelings. Thank you, Sarva. Next, I invite Dr. Guru Sandhya to share a few words.
Thank you, Shiva sir. Indeed, it's a great pleasure in being one of the organizing member of the online anesthesia, which we have completed some 100 hours of teaching. And thank you all the viewers and all the speakers who kept us supporting. Like there was no monetary benefits which were involved, but then to the passion of anesthesia, we were all connected with the passion of anesthesia and to teach the postgraduates. And the group has been overwhelming with messages, which thanks the organizer, Dr. Edward Johnson, sir. And all the best, sir, to the upcoming year, where he has posted its consultant forum where this session will happen once in a month. And thank you for the opportunity. Thank you, sir. Shiva, sir.
Thank you, Guru. I think Rajesh sir and Shantini are a little bit difficult to reach with their family. As all our teammates have said, I would like to extend my wholehearted thanks to all the participants first. It is for you people who we have been doing all this. So the overwhelming participation, it's really kept us going. I would like to also thank all the faculty guest speakers, because all of them, when we chose them and we called them, they gave their consent, prepared very good slides, a good enriched content, so that it reached all the students. And they did a really wonderful time consuming job in spite of their heavy schedules. All of them came, they taught us very well. It was very useful. And I would also like to extend my thanks to our sponsors, Aquarella and A1 Logistics. They did a very good supportive work all this 1 year. And thank you, Edward sir, for forming this group, because it is in your platform which we all have shown a very good stage show. I was really pleased to be a part of this team. And Rajesh, Shantini, they're not here, but they've contributed a lot. Guru Sandhya, all these people were very resourceful because they have a wide contact of all the consultants in this in India and abroad. Thank you very much. I especially thank Edward sir for being the platform for all of us, all 6 of us, to grow and show who we are in this online platform. Thank you very much, sir. And now I ask Edward sir to give a concluding remarks.
Thank
Edward
you,
sir.
sir. Thank you, all my team colleagues. And we ended with a high note, a high profile presentation by Sunil Pandya, sir. It's the right presentation in the right time. Thank you, Sunil, sir.
Thank you. Always a pleasure.
Thank you. Thank you, all the faculties. You have shown a great affection towards our program. So you have presented throughout this program, and you have given a good feedback about this program. I thank all the faculties and also the sponsor Akrola and host A1 Logics, and most importantly the viewers. Even today, even though it is a Christmas day, there are more than 200 viewers are in the online YouTube channels. So I thank them also, and we will meet next year with another different type of presentations concentrating on the anesthesia update for the consultant. Thank you, one and all. We will meet next year. Thank you, and a happy new year.
Happy New Year to everybody. Thank you so much.
Thank you. Happy New Year, everybody.
Happy New Year.
Thank you, Silpa.
Happy New Year,
Yes,
sir.
sir.
Happy
Thank you
New
so
Year,
much.
ma'am.
Thank you, Sunil, sir.
Thank you, Azam, for being there with us.
Thank you, sir. Always a pleasure. Thank you, sir.
Bye.